everyone to OsteoBites. My name is Christina Iptoma, and I'm mom to Osteo Angel Dillon and the Director of Scientific Programs for MIB Agents. And today on OsteoBites, we are talking with Dr. Kenneth Rankin, a consultant orthopedic surgeon at Newcastle's Freeman Hospital, and he'll be sharing his research on fluorescence-guided surgery in sarcoma. Thank you so much, Dr. Rankin, for joining us on OsteoBites today. We're thrilled to have you. And
thank you, it's a pleasure.
Yeah, and thank you to Walker Smallwood for joining us as our panelist today. Walker is an osteo warrior, and he's also vice president of our MIB Agents Junior Advisory Board. A little bit more about our guest today. Dr. Kenneth Rankin is a consultant orthopedic surgeon at Newcastle's Freeman Hospital, where his specialist interests are in orthopedic oncology, including fluorescence-guided surgery for sarcoma resection and hip and knee replacement for arthritis. Dr. Rankin graduated in 1999 from the University of Dundee, and his basic surgical training was in Newcastle, followed by an MD investigating the cellular biology of bone metastasis. Dr. Rankin completed his higher specialist training in Perth and Dundee, followed by a return to the Northeast as NIHR academic clinical lecturer. His current post as consultant orthopedic surgeon and honorary senior lecturer is comprised mainly of orthopedic oncology, including the surgical management of bone and soft tissue sarcomas and metastatic bone disease. And he also carries out hip and knee replacements for arthritis. And as a clinical scientist, Dr. Rankin has developed an international reputation for translational research for the detection of circulating tumor cells in sarcoma patients, and has also carried out the world's first case series of fluorescence-guided surgery in sarcoma. Working in close collaboration with scientists at Newcastle's University, he leads a basic and translational sarcoma research at the Newcastle Center for Cancer. So welcome, Dr. Rankin, and welcome to everyone joining us today. Please feel free to add any questions for Dr. Rankin to the Q&A, and we'll monitor those and make sure those get asked. Before we start, and before Dr. Rankin shares the slides, just to note that there are several OR pics and tumor images in the slides. So just a heads up, if you're squeamish, you may want to listen instead of viewing today. And then before we get started, we have a few other announcements. Factor, you've heard about Factor hopefully by now. Factor 2023, June 22nd to 24th in Atlanta. And registration as of now is live. I'm going to drop the link in the chat so you can go ahead and check that out. We also have a limited number of Factor Travel Awards that are sponsored by our MIB Agents Family Funds. And special consideration is given to young investigators and attendees from outside the US. And applications for the Travel Awards are due on April 7th. We're also launching season 2 of our popular Osteo AYA podcast. Osteo Warriors Camille and Mia will spill the tea on all things osteo. And on our first episode of season 2, which is going to drop on March 16th, they're going to be talking about what it's like to be an amputee on college campus. So you can find that episode on our website and also on our YouTube channel and Spotify channel, and that's going to drop March 16th. And I'm saving the most fun news for last, which is we just launched our Out Barking Osteosarcoma fundraiser. So dogs are 10 to 50 times more likely to get osteosarcoma than humans. So canine and human osteosarcoma research really help both species. And so you can purchase a cute Out Barking bandana for your dog on our website. I'll drop the link in the chat. And not only that, but once you get the bandana on them, you can post a pic, get your family and friends to vote. And we actually have an esteemed panel of judges who also happen to be top veterinary onc researchers judging our photos this year. So you can submit for who worked best and a few other categories. So I'll drop the link in the chat for that as well. And then Walker, do you want to go ahead and introduce yourself?
Yeah, hi, I'm Walker. I think Christine already said I'm the MIB Junior Advisory Board Vice President and an Osteo Warrior. And I just want to introduce our guest today, Dr. Rankin.
Thank you, Walker. Shall I go ahead and...
Yeah, that would be great if you
share
could go ahead
my
and share your
slides?
slides.
Yes, thank you. It's a pleasure to speak to you today about this trial we are now setting up here in the UK called the SarcoSIGHT trial. Just to give you a little bit of background, I'm based in Newcastle upon Tyne in the northeast of England, so it's the sort of last biggest city in England before you approach the border into Scotland. We serve a population of about 3 to 4 million across to the northwest of England in terms of patients presenting with a sarcoma. And we have a very comprehensive service, and patients who have a sarcoma, we can offer all the treatments that they need. And we have an extensive research portfolio. And we also have a very progressive pathology lab that allows us to interface in terms of the research very effectively. In terms of my job plan, I've been able to do research throughout my training, and this has made a big difference to me. And my colleagues are actually very protective of my research time, which allows me to make a lot of progress. I think surgeons generally don't get enough time to do enough research. So I still enjoy going into the lab and doing experiments myself, and also supervising research in the laboratory as well. So what is the problem that we're looking at and discussing today? You are probably aware from the point of view of a surgeon, and obviously the patient, that when we are planning an operation, we want to do an operation to remove the sarcoma and not leave any of it behind. If we leave any of it behind, that would be called a positive margin. And a positive margin, as you'd expect, means you're leaving some cancer behind, and there's a higher risk of it coming back, and so that's local recurrence. And in general, it is associated with reduced cure rates, so the overall survival is not so good. But there are issues about it, because as surgeons and pathologists, we don't have a full consensus on what's on defining margins exactly, in terms of what is a very good margin versus a close margin exactly. And as I've mentioned before, surgeons are always very, very busy operating. So we haven't really done any large scale clinical trials where we're testing some what we call a surgical intervention, doing something different in the operation to see if that would improve how we can do our procedure. So, so essentially no sarcoma randomized trials with a surgical intervention have ever been conducted. And I have a case here of an osteosarcoma, actually, that is really useful and sort of comes through into the presentation later on as well. As you're probably aware, osteosarcoma patients tend to be, most of them are obviously in children, teenage, young adult age group, but some do present when they're older. And this gentleman presented with an osteosarcoma in his femur a few years ago. And this is the MRI scan. And essentially, I'm showing a section of it. And what we did was we also, from the MRI scan, had a 3D printed model done. So hopefully this makes it a bit clearer. But if you look at the model from the end on, that's how we're looking at the MRI scan on the left. And so the tumor is actually coming out of the bone. And then what we're always worried about is the blood vessels. So this is a good example of the blood vessels are not too far away. And that's the decision we make with our patients, isn't it? The first thing we look at on the scan and discuss with our patients is, are the vessels, can we clear the vessels? Because that's the decision between limb salvage versus amputation. So in this case, the vessel's quite close, but we can clear them. And then we want to get a good margin of normal tissue surrounding the tumor. So in this case, we're taking a section of bone, making sure the vessels are clear, and then removing it with a covering of muscle. And so this was a sort of diagram just to illustrate that, looking at it again from the end on. You can imagine, so this is the bone, the yellow in the middle, and the tumor has gradually obviously appeared, and it's grown and it's come out of the bone, and then but the vessels are still clear. So from a point of view of a surgeon, this is how we picture it, and we think, right, I think we can remove this and get a clear margin. So we can clear the vessels there. I've shown them there on the bottom left. And then we're going to leave muscle around the tumor and hopefully get a clear margin. And then we obviously do a reconstruction with a metal implant. Is probably the most commonly used technique for reconstruction in osteosarcoma. And that's the reconstruction in this patient. So in terms of then what happens, as again you'll know, there's the margin assessment by the pathology team who look at the tumor in a lot of detail. And when we then attend our team meeting, the surgeon is sitting very nervously to hear about, hopefully we have got a clear margin, and it's usually measured in millimeters, as you see here. And of course, the pathologist will also report on whether the patient, if they have had chemotherapy before the operation, hopefully the tumor has been killed off by the chemotherapy, which would then likely give a cure in the long term. And our colleagues in Birmingham, so that's Birmingham, England, not Alabama, they did a study and they looked at patients with osteosarcoma, and they showed very clearly that if patients did not have such a good response to the chemotherapy, so less than 90% of the tumor being dead, if they had a margin of 2 millimeters or less, then their chances of local recurrence were a bit higher than patients who had a better margin. So these are the figures here. So a quarter of patients, if the tumor was not dead or not as dead as we would like, and they had a margin of 2 millimeters or less, a quarter of patients were getting local recurrence in this series. So it illustrates the point that as a surgeon, you still want to get that better margin. But it would be useful to know up front before you do the operation how well it's responded to chemotherapy. And that's a big area of research going on in many centers. So better margins equals improved outcomes here. And
Dr.
so,
Brandon, I was just going to ask, I think you had mentioned that there isn't really a standard around margins, but I mean, is there, what's kind of what you would strive for margins? Like, is it the 2 millimeters? Is it 1 millimeter?
Yeah, so exactly. So that's why I was showing the Birmingham classification, because I think it's accepted generally that 2 millimeters is still close. It's uncomfortably close still, but it's probably, but if you were to say to a surgeon and pathology team, is that a wide margin? They would say, well, maybe some surgeons and pathologists would say, well, 5 millimeters is wide, and others would say 10 millimeters. So that's why we need more work on it. 2 is probably a bit close. So that's the problem. And so some of these definitions and how wide is a wide margin in terms of millimeters is not too clear.
Got it.
So how this trial came about was that, in fact, my colleagues who were doing colorectal surgery, they were doing a trial, and they were using this dye called endocyanine green, which is a very safe dye. It's been around for decades, actually. And what they were doing was giving the patient the dye into the vein during the operation and holding what's called an infrared camera to detect the fluorescence. And you can see it here in green. And apologies again, some of these pictures are not too pleasant to look at, but basically the normal healthy tissue will glow green quickly, or fluoresce as we call it, quickly, and the cancer tissue will fluoresce later. And so that allows them to identify where the healthy tissue is, and they can remove a section of bowel, join it back together, and that means they're joining healthy bowel back together, and therefore the risk of it failing and leaking is reduced. However, the concept for trying to visualize a tumor is a bit different. What you do is give the dye into the vein of the patient the day before surgery, and the concept is it circulates for not that long around the body, but actually it stays in the tumor. And I'll show you some data later on that within 30 minutes it seems to be taken up by the tumor, and it's still there the next day. So the other game changer was that companies have started to produce infrared cameras that are really user-friendly. And this one we use on the right here, it just looks like a barcode scanner, but basically it's very user-friendly, and you can use it in these big open operations that we do. And so that's how we embarked upon the project in terms of starting to do some cases. And the first case that it worked well on was back in March 2019. This is a patient with a very large, this is not an osteosarcoma, a chondrosarcoma in the pelvis. And again, sorry again for these sort of surgical images, but basically when we were looking at this, having completed the operation and looking at the tumor, you can see me in the bottom left pointing the camera at the tumor, and then you look at a TV screen. So you've got a stack here that the camera is connected to, and then it shows you an image on the TV screen. And when I cut into the tumor, it was definitely fluorescing, as you see. And so that was really the eureka moment that actually this may work for sarcomas. And we went on from there to do more cases, and we've done over 70 bone and soft tissue sarcoma cases to date. This is just another case. There's various what we call infrared modes. This is a black and white type mode, which is a bit more sensitive. And it just shows an area of sarcoma. This is a soft tissue sarcoma. It shows a vessel going across it, but you can see it's very bright. And actually, when I've taken a bit more tissue to improve that area, you can see it's cleared it up and got a clear margin in this patient. So that's the concept. But really, the question was, what are we going to do? I mean, how do we test this technology? And well, as we know, I mean, randomized controlled trials are the gold standard for assessing whether something really does work or not. And if it's going to work, it's got to work in the real world in different centers with different surgeons. And so we sat down with our cancer trials team. There's a football or a soccer manager who's late now. He passed away a few years ago, called Sir Bobby Robson, and he's famous in the UK, and he managed Newcastle United and also the England national team, and he left funds to form a foundation, and that allowed them to put together a cancer trials team. So we met pre-pandemic December 2019 to start to talk about how we could build a trial. And it's interesting because we met face to face, and all the meetings were then sort of virtual after that. And I haven't actually seen them face to face since, but we had dozens of meetings. But one of the first things to do was to publish the first case series. So just 11 cases, but because it was the world's first case series report, it was published just to show that we were quite a range of sarcomas were fluorescing with this technique. And then also looking at some data, just saying, again, what I've said before, that if you have a positive margin, then there's a risk. So LR is local recurrence. There's a high risk of this sarcoma coming back. And also that can impact on survival for our patients. So this was really to convince our funder that it's an important area to tackle, and we can improve these margins, obviously, with better surgery. And so it was quite a process to put this together. So the National Institute for Health and Care Research in the UK is maybe a bit similar to your NIH, isn't it, in the States, but basically a big funder of massive projects, and quite a process to engage and put applications in. So we eventually submitted our first stage in April 21, and then the second stage in January 22, and did lots of work with all the centers around the UK. There's 19 sarcoma centers, and it was a lot of work, but eventually did get the funding through, and that was confirmed a year ago, actually, March 23. What was an obvious thing to do was to look at, as we started doing more cases, was to compare the positive margin rate in cases over the couple of years by then we'd been using the technique versus cases that didn't happen, we hadn't used the technique. And actually, it gives an indication that perhaps it does help because the UPM, as the unexpected positive margin rate, was up at 25% compared to 5% when we were using the infrared camera, and obviously we'd given the dye prior to the surgery. This was a mix of, again, bone and soft tissue sarcomas. So obviously we kept going. What was really important, of course, is to have a working group with patients and the public. You may have come across Roger Wilson. He's well known in the sarcoma world. He's a sarcoma survivor himself and founded a big charity in the UK called Sarcoma UK. So he's our PPI lead. And we have a nurse consultant here in Newcastle who runs a patient group called the Patient Perspectives on Cancer. And that was really important because it brought in, apart from sarcoma patients, some of them who'd had the dye and the infrared as part of their surgery. It also brought together a diverse range of patients who'd experienced cancer and had also experienced cancer trials. So it was really, really important to put it together so we could ask questions about their experiences, as well as whether should we randomize or not. Some of them had a strong opinion that this sounded like a great technique. Why not just run a study where you use it for all patients and compare it to patients, as we did in that little case series that hadn't happened to have it, historical cohort, we would call it. But ultimately, we did agree that if it was to become standard practice, it really needs to be shown that it works in a randomized controlled trial, again, across multiple centers with lots of surgeons involved. And then there were lots of discussions about the outcome measures. What are you measuring exactly? And the primary one, as we call it, is that margin rate. Can we reduce that positive margin rate and get better cancer outcomes for our patients? And so lots of work with the patient group, and they helped, of course, with our plain English summary, and they continue to be involved, of course, as we set up the trial, and as we deliver the trial, they will be involved. And so obviously we worked with statisticians, and essentially what we've done is power the trial based on some data, that the previous data showing that the positive margin rate in 224 patients is 13.8%. And if you're going to drop that to 5%, as the recent case series, then you need 500 patients over 2.5 years, 250 have the dye and the surgeon uses the infrared camera, and 250 don't have the dye and the surgeon doesn't use the camera. And so that's basically it. And if it is better to use the camera, then it'll show up on those statistics. And of course, secondary outcomes, we're doing functional outcome measures like the Toronto Extremity Salvage Score as an example. And of course, in the longer term, we'll be looking at rates of local recurrence and survival. So there's lots going on in this slide, but it's basically the flow chart just showing that 250 standard of care, so without the fluorescence guidance, and 250 with fluorescence guidance, and then as all trials do, picking up adverse events, and then we have the follow-up where we're looking at functional outcomes and patient-reported outcomes. We also have an interesting pathology sub-study and an imaging study, and I'll show you some details of that. The intellectual property has been interesting. We have one company, Stryker, providing the camera, and there's quite a lot of discussions about that, but I won't bore you with those details. So ultimately, the trial is funded at £1.5 million. So I think that's just over $1.5 million US. A lot of that goes to the trials unit. I did remember to cost some of my time in because it is taking up more and more of my time. We have a trainee costed into it, and he's working on it. He's learning about how to be an academic surgeon. That's really important. We've also costed in care for the patients, particularly if they have to come in the day before for the dye injection, and of course costs for the dye. What was really interesting, and again going back to my interest in taking things back to the lab and looking at the pathology in detail, was to see if we could see the dye, under a microscope in the pathology lab, and we did quite a lot of work, and eventually we've got there. So this is a case, this was a soft tissue sarcoma, but basically here is some tumor in a paraffin block and versus some muscle, and we put the camera on it and you can see the tumor is glowing green in this paraffin block. And this is very old style pathology, but the camera can detect the dye. And even when we cut it into a 3 micrometer section, so tiny, wafer thin, but a standard very thin section for pathology, where you can use another imager and we can still detect the ICG. So we did quite a lot of work to find a microscope that could look at the cells in detail. And we realized that actually most microscopes available at most universities can't image ICG very well because it's in the far red zone, we call it. And they're not really built to do that, but we did find one eventually. And I'm going back to this case because essentially we had given this patient with osteosarcoma the ICG the day before surgery, and it did fluoresce impressively because he didn't have chemo. He wasn't fit for chemo. So it was active. This tumor was still alive when we removed it. And sorry again for the surgery photograph, but at this area that we were worried about, fairly close to the blood vessels, you can see there's green coming through the muscle. And we were able to call for what we call margin block. The margin there was about 1.4 millimeters, and that's really the sort of distance here, getting close to the tumor. And I put a white line where the boundary is. But what's really exciting is that with this slide scanner that we used, we could zoom right in and start to actually look at the osteosarcoma cells with some ICG in there. And also what was interesting is the ICG seemed to pool in areas of hemorrhage and necrosis. So this was some really exciting imaging that we started to get through. The issue with ICG, though, across here in the normal tissue in the muscle, is it is present there. And so we do need to develop better dyes, or targeted dyes as we call them. And I'll show you some examples of what we've been doing in terms of that.
Yeah, so what is actually the dye attracted to? I mean, what is it? Because I think in one of your earlier slides, you had mentioned the vascularity when it was being used for colorectal cancer. So is it the blood vessel activity in the tumor, or what is actually the dye honing in on?
Yeah, so what we think is then when it is injected into the vein the day before surgery, like any drug that's injected into somebody, it'll go around the circulation and it'll go around all of the normal tissues at whatever rate it does, and then the body will clear it. So for ICG, the half-life in the circulation is quite short. It's actually measured in minutes. But what we think is it clears from normal tissue, but it slowly sort of gets into the tumor, and the tumor blood vessels are a bit abnormal. So it sort of gets in fairly slowly, but it gets stuck. And you can see it's pooled in here. So these are pools of hemorrhage and necrosis. So if you look here, these are red blood cells actually, and the ICG sort of leaked into these pools of blood, and it stays there. Again, because the blood supply to the tumor is abnormal, it can't really get back out. On top of that, the cancer cells have a mechanism where they start to take it up and hold on to it. So there's sort of two concepts there that we think are the reason that it stays in the tumor. And so that's why we investigated it a bit further, and by taking some dye into the lab and growing some cells in a dish, and actually there was an excellent paper from Japan. They were using colorectal cancer cells, and they were suggesting that there's this, what we call endocytosis pathway, that the cells are using to take up the dye. And cells, like cancer cells that are dividing, they're proliferating quickly, they're active, they happen to have this pathway switched on. So they just happen to take up the dye, not because, just by accident almost, just because they're very active. And so we started to repeat some of the experiments from that Japanese paper. So here's a breast cancer cell that grows quite slowly. You can see it's not very green, but this sarcoma cell line grows very, very quickly, and it actually takes up loads of dye. So that was the start point. And actually then we did some more experiments showing that. So here on the x-axis is cells if they grow very quickly, so these cells, these HT1080 cells grow really quickly, and they take up loads of dye. So that's the dye measurement on flow cytometry. These two are osteosarcoma cell lines in the middle. So they're somewhere in the middle, obviously. So they grow relatively quickly, but not as quick as these, but they take up a fair bit of dye. And there's that breast cancer cell, again, it grows quite slowly, but takes up less dye. This is another osteosarcoma line that grows quite slowly and takes up a bit less dye. So it's a little bit similar to thinking about the grade of a sarcoma. The higher the grade. So this chondrosarcoma line represents a really nasty type of dedifferentiated chondrosarcoma that's really, really nasty for our patients. So yeah, so that was trying to model that. And also looking at the pathway using this, what we call Pitstop 2 chemical, blocks that pathway. So if you put that on the cells, they don't take up the dyes, you see, so efficiently. So there's not much green there compared to the negative control Pitstop that's in an inactivated form and it's taking up the dye. So that was really just to get some understanding of the cellular mechanisms underlying all of this. And so for the trial, we have this sub-study where we make, and we did this from this tumor. So I asked the pathologist to make a standard H&E, which is very standard pathology. You can see the margin there. We have a sarcoma marker that we've been validating called MT1-MMP, and I'll talk about that a bit more in a minute. And that really picks out sarcoma cells extremely well, and that shows the margin again. And then I asked them to, so the blue is DAPI, it's a very standard fluorescent dye that picks out any cell's nucleus, it binds to DNA. And it's very useful so that you can just at least know there's cells on the slide, basically. And then you can see the ICG dotted about. So that's the pathology sub-study, which we'll do on up to 50 patients in the study. And then we haven't done huge numbers of osteosarcoma patients so far in this project. But there was a case recently where this was a young adult with an osteosarcoma of the proximal tibia. And you can see again on the MRI, as a surgeon, this is the area I'm most worried about, actually, because this is the calf muscle here. And I want to try and remove this, but I'm in danger of getting too close to the tumor here, actually. And so again, I want to remove it. The blood vessels are at the back here, they're okay. But these bits of soft tissue tumor that have come out of the bone, I've got to avoid them. That's the difficulty I have as the surgeon. And apologies again, but I'll show you the tumor once we'd removed it. And so the top image is, this is the calf muscle here. And this was the area where it's close to tumor. And it's a bit faint, but on this mode, infrared mode, if it's blue, there's a fair bit of ICG not far away there. If you bear in mind, the infrared means that the ICG is deep in the tumor, and so the fluorescence, the glow is coming through some normal tissue to get this image. And that to me was a bit worrying, because I was thinking, if we're getting this pickup, then maybe the tumor is still alive. And unfortunately, when we got the report back, at best, the tumor response was only 60% necrosis. And the margin in that area is 3.4 millimeters. So that's the tumor fluorescence coming through 3.4 millimeters of normal tissue. And so this is really the point, particularly for osteosarcoma, that actually during surgery, you may be able to predict what the necrosis is, and you might be able to do something about it. There's the ICG is a photosensitizer. You could put an infrared lamp, not on the tumor, obviously, once it's out, but actually on the wound bed where you'd be worried it could come back, and treat that area for maybe 20 minutes, and perhaps that would reduce the risk of it coming back. So we're actually already thinking of designing trials to add photodynamic therapy in if we see this scenario. So yes.
Could you also do radiation, like a high dose radiation, I think, as well in the OR?
Yes, absolutely. Yeah. So the Japanese that we're so we've set up a bone Sarcoma Fluorescence Guided Surgery Consortium. And that does include a team in Japan who have done a big study actually about 10 years ago now, where they were using photodynamic therapy and also brachytherapy to treat that area with both modalities, so radiotherapy plus photodynamic therapy, and reporting good results. So yeah, so that is definitely a possibility.
And so I have to say, one of the slides you had earlier, I think, where you showed the dye and the tumor, and there was the green dye that was outside the main tumor area. Like, you know, when I see that the green, it's like, oh, you know, seems worrisome, but is that just the uptake? So I know you were saying you could see the green coming in through the tumor bed, knowing that. But what about the green that was kind of showing up kind of on the perimeter of the tumor?
Oh, on the pathology slide.
Yes, I forget which it was. The slide, it was like a dark slide, and the tumor, and you could see all
the so this is the problem. So what we think is that a lot of the dye is staying in the tumor, but some of it is lingering in the tissue around the tumor, because the tissue is a bit reactive around the tumor as well. So there's a bit of it lingering in that area, and that's why we need to get dyes to work better, you know, to be more targeted to the tumor rather than some of it lingering in the tissue nearby. That's why we do the injection the day before, because we have done cases where we've injected on at the time the patient is having the anesthesia, and we find it's too bright, everything's glowing everywhere, and it's because there's too much dye hanging around normal tissues nearby as well.
So what's the ideal time period that you found?
So essentially, to be practical about it, it's admitting the patient at lunchtime and doing the injection in the afternoon. And this was backed up by a team at St. Jude's who did a trial for pediatric solid cancers. And actually their methodology is identical. So they inject the day before, and they actually published their paper and showed good results. And they had quite a number of sarcomas in their series. I can't remember exactly how many, but about a dozen sarcoma cases amongst other pediatric cancers they were evaluating. So yeah, so the osteosarcoma cases to date, so it's interesting. So the case I've showed you that I started off with was the elderly patient, and he was not fit for chemotherapy, so we went straight to surgery, and the fluorescence was clearly evident. We had a patient after that who was middle-aged, who did have chemotherapy, and there was no fluorescence whatsoever, and came back as over 90% necrosis. And then there's the case I showed you of the tibia, and again, the patient had neoadjuvant chemo, but the fluorescence was evident, and only 50% necrosis. And there's been another recent case, no fluorescence, but again, at least a good necrosis. So that's all obviously very small numbers, but that seems to fit together.
That kind of map with what you're saying about being able to predict necrosis. So in those, I mean, it was just in those few cases, but if there was high necrosis, the dye didn't take up, right? In those.
Yeah, exactly. Yeah. And that's different necrosis to the necrosis I showed you in that case where the tumor is active, and it's basically outgrowing itself in places, and then it's hemorrhaging and necrotic. The type of necrosis you get from chemotherapy or radiotherapy is very different. It's not the same. It's more like a scarred up. It activates the tumor, and the cells die off and it scars up. So it's very different to necrosis from an active tumor, if you see what I mean. Yeah.
Yeah. I mean, is there any way that, because, you know, right now the dye, you basically have to go in, open up, and then you can shine the infrared camera on it. But is there any technology where the dye, where you can actually see it, the imaging with the dye, like without having to go in? Is that
yeah. So the other thought process we have is actually thinking about PET MRI.
Mhm.
And actually, I'll cover that just now in some of the work we've done, laboratory work we've done, because the concept in terms of creating a targeted dye is that you have usually what we call a cell surface target. So the cell's got whatever on its surface. In Ewing's, that we all know about CD99 as an example. In osteosarcoma, I'll show you that MT1-MMP is highly expressed, and this is an enzyme on the cell surface that actually causes the cancer cells to break down bone and invade and metastasize anyway. So if you have an antibody to that and you add on a infrared dye, as I'm showing you here, that's the concept of something binding to a cell surface target with the antibody with the infrared dye on it. What you can also do is you can put a radio tracer on it, and then what you could do is a PET MRI. Then you might be able to work out, you know what, this tumor is not responding, and you might actually change the regimen, the neoadjuvant chemotherapy regimen, earlier to something that may work better, so that then by the time you do the surgery, hopefully it's the necrosis rate's better, if you see what I mean.
Yeah, that'd be super cool.
Yeah, I mean, I've got this. Sorry, yeah.
Sorry, a question just came in, and it's: would it generate better specificity and contrast if the dye ICG were connected to targeting ligands such as somatostatin? Somatostatin receptor is upregulated in bone cancer cells.
Yeah, so exactly, this is the concept. So this is why I'm showing this sort of, these orange circles here are something, yeah, exactly, a receptor or a whatever that's on the cell surface, and then you can target that somehow. Here I'm depicting a monoclonal antibody with infrared dye 800, because that is on the same wavelength as ICG. Therefore, you can use the same camera that we use already. And we have had discussions. Maybe we could just put ICG on something that targets some a receptor or protein of interest on the cell surface. Yes, that's exactly what we were thinking about. Yeah. I mean, I'm just showing you this little schematic about osteosarcoma because I did it 12 years ago and it all held up. But it's a little animation that shows, as you'll be aware, osteosarcoma we think happens because, and the reason it happens in the age groups it happens in is because, and where it happens is near the ends of the long bones where there's a lot of bone growth. So osteoblasts, bone forming cells, very active, and they have an event and become an osteosarcoma cell. And then they overexpress this enzyme MT1-MMP, which will cut collagen. So type 1 collagen in bone is the most common collagen. It also activates other MMPs and can facilitate metastasis. So Christina mentioned I'd done some work on looking for circulating tumor cells, and actually we use that as a way of trying to detect them in patient blood. So we have a study in the UK where we do that routinely. And that really, so knowing all of that has allowed us to go on and use MT1-MMP as the target on the cell surface. And here was just some early data showing on a Western blot, for example, that again, the chondrosarcoma cell is highly expressed. Here's an osteosarcoma cell, it's highly expressed. That breast cancer cell, it doesn't express it. But we know in carcinomas that are behaving aggressively, and from a surgical point of view, I also deal with them when patients get bone metastases. They behave almost like sarcomas, and they happen to express it. But again, so that was just showing that, but also here's some tissue, and the brown, essentially, intense brown means lots of MT1-MMP on the cell surface, compared to that's an osteosarcoma versus a benign bone tumor, an osteoid osteoma is very weak. And again, we were talking about dogs earlier, isn't it? So we did a little study with the Cambridge Vet School, and large breed dogs, as we've already discussed, are at risk of developing.
Really large dog. I'm sorry.
Irish Wolfhounds, yeah. So they're at risk of developing osteosarcoma. And we think it's because of that rapid growth, very, very rapid growth spurt they go through from a puppy to a massive dog within a couple of years. So that's why we think they're at higher risk of developing osteosarcoma. They just have a lot of bone formation in a very short space of time. And then when we looked at MT1-MMP in these dogs, a range of sarcomas, but most of them were osteosarcomas, really strong MT1 staining was predictive of survival, right? And we've done a patient series as well, which we're working up for publication, which shows the same. So it's a really compelling target. And it's not just us that have been working on this. Team at MD Anderson with Richard Gorlick have noticed the same. And actually taking patient material, so one of our patients was keen to donate his biopsy sample, so it was still viable, and for patient-derived xenografts, we had mice developing tumors. And again, if you stain for MT1-MMP in the mouse, actually in the mouse primary and in the lung met the mouse developed, then the MT1-MMP is highly expressed. And this was a hero of mine, this patient, who was with Mo Farah, quite a famous long distance runner. They did the Great North Run together shortly before patient passed away. That was him finishing half marathon in 5 hours 38. Yeah, a real inspiration. So yes, and this has been noticed by the team at MD Anderson as well, and they were testing a therapeutic. So it's a really compelling target. But we've taken it from the point of view of, can we use it for imaging? And so we have a pipeline where we can stain our sarcomas with a good working antibody. And this again depicts the margin. We can pick out the margin. And then our radiochemist can put the IR dye on it. He can also put zirconium-89, and that's the concept. You could do a PET MRI scan before an operation and see if a tumor is viable. And that's just some basic experiments showing that he's managed to label it properly. And actually, when we did a CRISPR knockout of the MT1-MMP in these sarcoma cells, they're not binding the antibody, so that was quite nice. And then we did some work where we've got a mouse tumor here, and it's staining up well. And this is a patient example staining well, and you can see the margin very clearly. And you can see then when we put the labeled antibody in, it's glowing, and it's also radioactive. So we did a little mouse clinical trial, and basically we could show that the xenograft, as we call it, so the bone sarcoma in the mouse femur is fluorescing and was also radioactive. So the attractiveness of the zirconium is you can actually make the zirconium fluoresce via Cherenkov luminescence, which is another technique which we're exploring. And these were the tumor samples, just showing again they're fluorescing and radioactive versus the knockouts and some controls. And so based on all this, we've got some funding from our UK charity, the Bone Cancer Research Trust, who are a very supportive charity, to set up a consortium to work together. So obviously I'm based in Newcastle. We have a scientist at Imperial College London who's got expertise in phage technology, which would be another way rather than an antibody. Phages are quite useful to target, particularly usually cell surface proteins of interest. And then our colleagues in the Netherlands have useful, again, models to study. We have a really interesting interaction with a team in Harvard, and they have they've got better imaging techniques, something called FLIM, which is fluorescence lifetime imaging. And again, we've got the data in for publication. I'd love to show it to you, maybe in Atlanta, but basically this really gets a much better image, much clearer, and that's just a much better camera. And I mentioned our team in Japan. We've got the expertise in photodynamic therapy. So we're putting this together and really so that we can start to accelerate our research. And in fact, we're interacting with a colleague in Montreal who's doing cases, and Kurt Weiss in Pittsburgh is also doing an ICG study. similar methodology. So we're all interacting actually across the world to try and pool our expertise. So I think that's about everything from me. Just thanks to, there's so many people that have been involved, as you can imagine, our patients, of course, who've been instrumental in interacting, particularly for the trial designs. That's our radiochemist, Dr. Knight, and his PhD student, Tony. Marcus, who is our academic trainee, who's got a statistical brain that's great. I mean, he's better than me at it, so really effective. Corey, who's done a lot of the lab work on the cell mechanisms. Samir and Helen do the in vivo mouse work. My colleagues in Newcastle, very supportive, and around the country have been involved. The Bobby Robson Cancer Trials team. We have a charity, Orthopedic Research UK, have given us funding. Stryker have been a good company to work alongside. And that was a trials team, and there's so many people involved, statisticians, methodologists, co-investigators, our pathologist, Prof. Burt, and Ronan Cahill's a colorectal surgeon in Dublin who's going to lead on to study the images we get from the trial in a lot of detail. More and more people, business development managers, pharmacists. Yeah, it's quite an effort to get to this stage, I think. So just to acknowledge everyone who's been involved.
Thank you. Yeah, I imagine it's a huge effort to get a study like that off the ground and going. And so you had mentioned 500 total. So 250 with the dye, 250 without. And how long do you think it will take to recruit that sample?
Yeah, we're hoping to do that in 2.5 years.
Okay.
Which we think is doable. And so 1/3 of patients will have a bone sarcoma. So probably about half of those will be patients with an osteosarcoma, something like that. So, so there should be a good number of osteosarcoma patients into the study to obviously look at these, try and answer some of these questions, as I showed from a handful of cases. Can the fluorescence predict necrosis as a key point?
A couple of questions coming in. Walker, do you want to take those?
Yeah. So one of the questions is, I'm sure the decision to have a control group was a difficult one. If you see meaningful benefits for the ICG group early, are you obligated to continue with a full 250 patient control cohort, or would you change that?
It's a good question. Yeah, so there'll be an interim analysis to pick that up. So if we we expect that interim analysis to be slightly more than halfway through the recruitment period, because usually it takes a while to build up. So it won't be like sort of exactly 1.25 years, but basically there will be an interim analysis, and there is a data monitoring committee to look for that. And because we will, if the positive margin rates are obviously lower in the intervention group, that will get flagged. If not before the interim analysis, certainly during the interim analysis. And if it's found that it's very obviously better, then we would have discussions. I think usually what happens is the trial gets closed, and basically the idea is all patients should have it. But there would be obviously a discussion at that point.
Okay. And then are you accepting pediatric patients is another question.
Yes, absolutely. So I was really keen not to have restrictions, and because the dye is very safe, and as I mentioned, St. Jude's had done a really excellent phase 2 trial on pediatric solid cancer. That was actually really good to see from the point of view that there were no major problems with administering the dye in that age group. And so that was really the important point, was to make sure pediatric. So there's actually no lower age limit at all, and there's no max age limit the other way. Yeah.
I know personally, when I had a lung resection, I guess it was in 2020, and I got some kind of dye, and I can't remember. It was a green dye, but I don't remember the name of it. Would it have been like the same dye, or would it have been like something completely different?
It's pretty likely because the first reports of there were case reports from thoracic surgeons using it for metastacectomy for sarcoma, actually. Yes, so there's a fair chance. There's a group in Philadelphia that had some, there were case reports basically of using it. Whereas our series was the first series of open, resections on primary tumors. But yeah, there's certainly reports for removing lung mets thoracoscopically, I think, usually.
Yeah, that's exactly what it was. And I went in like a day before to get the dye, so that
exactly.
definitely sounds right. Yep.
Yeah. Mm-hmm.
So on that note, I mean, is this something that's pretty already readily available at many institutions, and it's more just the application of it for this type of surgery? I'm just curious if, there's good data coming back, how easy is this to kind of be rolled out at many institutions? It sounds like it's just the dye and then the special camera. And then is that an easy thing to roll out? Doesn't sound like it's a tremendous investment from an institution.
Yeah, no, exactly. The dye has been around for decades, and it was really the cameras that have come along and expanded the indications for the dye that way around. So, and so the cameras are the expense, I suppose. They are somewhere in the region of $100,000 US dollars, something like that, for a system. But once they're in a center, they can be used for all sorts of indications. So tissue perfusion, plastic surgeons use it to look at their flaps. So the patient has a shot of ICG, and then they watch it come through the flap, and they can see an area that doesn't have good perfusion and do something about it. There's lots of work done on lymph node detection. In fact, we have 2 cameras, and our breast surgeon keeps stealing our camera, even though we bought it for, actually our plastics team bought the second one. And we keep saying, can you have a camera back? Because he finds it very useful. So, yeah.
Yeah, that's when you got to get your label maker out.
Yeah, that's right. Yeah.
Put your name on it.
Yeah.
All right. Well, so exciting and really interesting. And I mean, just kind of thinking about the different ways to be able to kind of target the dye better, but I think really interesting too with trying to make, think about the kind of the PET possibilities so that you could potentially see this before even going in to help with better planning and predicting necrosis. I think is really exciting. So thank you so much, Dr. Rankin, for joining us on OsteoBites today and for making it better for sarcoma patients everywhere. More information on this and all OsteoBites can be found on our YouTube channel, on our website at mibagents.org, and at your favorite podcast place. And if you want to learn more about Dr. Rankin's work, come to Factor in Atlanta because he's going to be there. And so we're so pleased he's going to be speaking on a couple of our panels at Factor this year. And please join us next week on March 9th. We're going to be talking to Dr. Kelly Bailey. She's going to be discussing her recently published paper on how Ewing sarcoma and osteosarcoma have distinct immune signatures and intracellular communication networks. And you can find our OsteoBites lineup for the next few months on our website. If you have any ideas for future topics you'd like to hear about, feel free to share them with us at events@mibagents.org. And thank you again, Dr. Rankin, and to Walker, and for all of you for spending an hour with us today. And we hope to see you next week when we chat with Dr. Bailey on the 9th.